Good afternoon. Today's TV webinar series is Evolution of the TVN Ethical Policy Framework. So this is our normal regular forum where Canadian and international experts share research insights on advancement in assessing and caring for frail elderly Canadians. Today, we are pleased to present an update on TVN's progress in developing an ethical policy framework. If you were at our conference, you would have seen this session, and I know that many people have missed it, so today is to accommodate those that have missed this session at our conference. This framework applies to the entire TVN network over the course of all research activities, with the goal of making sure that new insights into frailty awareness as well as frailty screening and evaluation embrace thoughtful reflection on Canadian values. And just before we begin, I'll do a TVN update. The transformative research grants, the full applications are due on December 1st, so this is just a reminder. The 2015 Catalyst grants have already been submitted, and the results will be announced in March of 2016. Our new one-year fellowship, they're in review. They will be approved by our board on December 4th, and the announcement will go out just after that. Upcoming webinars, Wednesday, December 2nd, we have Lisa Burry from Mount Sinai Hospital doing a systematic review of antipsychotics for management of delirium. And January 2016, we're not sure of the actual date, but we will be having the scoping review of the communication technologies for engaging patients, families, and caregivers in the healthcare system. During the session, please submit questions and we will answer as many as possible. Paddy has a lot of questions embedded in her presentation and lots of opportunity for discussion. This webinar is being recorded and will be posted on the TVN site for downloading within the next couple of days. Normally we have it up within 48 hours, but we just give ourselves some extra time. So now I will go forward and talk about our presenter today. Many of you already know Paddy Rodney. She's an associate professor at the School of Nursing at UBC. She's the former founding board member of the Association of Registered Nurses of BC. She's a faculty associate with the UBC Centre for Applied Ethics and a research associate with Providence Healthcare Ethics Services. She serves as an ethics consultant for the BC Provincial Advisory Panel on Cardiac Health. Her research and publications focus on end-of-life care for seriously ill older adults and the moral climate of healthcare delivery for healthcare providers. She is working with colleagues in Providence Healthcare Long-Term Care on research to understand and address staff distress related to increased mortality rates of residents soon after admission. Today, Paddy is on a cell phone doing this presentation, so I will be moving the slides forward for her. Hopefully, there is a storm out where she is. Hopefully, she won't lose reception. So I will be starting her slides in 2 seconds. Just go here to the first slide. There we go. So Paddy, we're ready for you to start your presentation.
Excellent, excellent. Thank you, Carol, and welcome to everybody who's online. And so I know we have people, a wonderful broad audience from across the country, so I'm saying good afternoon to some of you and good morning to others. And I also know we have colleagues from Quebec, so bonjour. My apologies for not being able to do this in French. I also want to welcome the fact that we have also patient family caregivers online, so this is a fabulous group to be able to present to. I want to acknowledge, as you can see on the first slide, the co-author and really the intellectual leader in this work who's done a great deal on ethics in general and specifically ethics in policy, and that's Dr. Sister Nuala Kenny, who is a professor emerita from Dalhousie University and has been one of the board members in the Technology Evaluation in the Elderly Project. So in speaking, I am speaking for both of us in terms of what we have put together. So if we go to the second slide, and Carol, thank you for advancing these for me, I do want to just make a couple of comments about our overall goals for this session, and those are really to provide an overview of what we've created in terms of the TVN ethical framework, both the substance and the processes, to discuss related challenges and opportunities, in particular focusing on future plans for TVN and also for those of you who are researchers, users, and so forth of TVN policy work, to explore your related interests, and to point to implications for other ethical frameworks for health and healthcare policies. So those are some of our goals. We will be having, as Carol mentioned, a bit of discussion around 2 case examples I've embedded in this presentation. And I will mention that at the end of the PowerPoint presentation that you have downloaded, there's some related references for your follow-up. So going to the third slide then, specific objectives within those overall goals are to really focus on the importance of ethics in health and healthcare and health research, review the meaning and utility of an ethical framework, analyze the foundational values that we've put together for the ethical framework for TVN, operationalize an ethical framework for the seriously ill, frail elderly and their families' caregivers, and that's the point that we will look at in terms of some case discussion, and to discuss implications of applying the ethical framework in ongoing practice, research, policy, and knowledge translation. And those implications are clearly for work in TVN as well as beyond. So I'm going to start with a bit of didactic flow through some of the slides in terms of background context. I know that many of you in the audience will have fairly extensive background in ethics, and for some of you this may be relatively newer territory, so it's worth doing a bit of review. So I think some clarification around terminology. One of the things that drives an ethical framework is values. And as you can see in slide number 4, values are generally understood as principles or standards of important judgment of what's important in life. And something about values is that they are lasting and they are shared within cultural groups regarding the good and bad or desirable and undesirable. And by cultural groups here, we don't just mean ethnicity. We mean shared systems of meaning within healthcare delivery cultures, systems of meaning within, for example, rural and remote communities, Aboriginal communities, and so forth. All of those values are important and located in diverse populations. The principles that Dr. Kenny and I have outlined are that are linked to the values that I'll be telling you about that we've articulated are ways to think about guides to decision-making and action, and they embody those sets of values. So the important thing I want to emphasize in this 4th slide is that ethical frameworks are not just a theoretical idea. They're really meant to guide practical decisions and actions. And those decisions and actions can be at the level, clearly, of patient care, research, subsequent policy work, knowledge translation. And our focus here today is less on patient care and more on looking at research, policy work, and knowledge translation. So I do also, I won't read through the entire slide on the 4th slide, but I do want to note also that the TVN board has been really actively engaged in helping us to articulate these values. They have responded in board meetings to some work that we've done together. We've also presented at a couple of TVN conferences where the audience engagement has really assisted us in moving these ideas forward. So let's get to the specifics next in terms of what the ethical framework values are. So on the 5th slide, there's a summary of the 5 values that Dr. Kenny and I have pulled together that we believe best represent the important action and initiatives that are inherent in TVN and the communities it serves. So the list of 5 then include respect, empowerment, equity, collaboration, and innovation. And I'm going to go through these one by one. Again, you'll have the slides for reference for yourself that offer the definitions. I'll talk through them, and then what we will do is we will spend some time looking at their application with a couple of case vignettes. And you'll have a chance to, at least a few of you will be able to sample some of your questions and responses within those case vignettes. But moving to the 6th slide, let's elaborate on respect. So by respect, we mean respect for the dignity, diversity, and autonomy of frail elderly individuals and their family caregivers, especially, although certainly not only at the end of life, but it is clear that approaching end of life, which can be a long trajectory, is a place where issues of respect clearly surface. So the elaboration that we've offered for you is that this respect acknowledges differences in physical and cognitive health, family and community supports, and sites of residence and care. In other words, we look at the location within the healthcare system as well. So this respect is expressed in healthcare decision-making, healthcare practices, healthcare research, and healthcare knowledge translation. Moving on to the 7th slide then, the second principle that I want to elaborate on is this notion of empowerment. And again, want to say how delighted I am to know that we have family and caregivers on this teleconference, because I think it's one of the means of empowering people who are not just healthcare providers. So empowerment, as this 7th slide elaborates on, is empowerment of the frail elderly and their families' caregivers in all levels of care and decision making. And so what we have elaborated on here, again with input from the TVN board and TVN members overall over a couple of conferences as we've crafted these values, is that this empowerment is supported by timely, comprehensible, and evidence-informed communication, which is sensitive to patient-caregiver needs, values, beliefs, and cultural backgrounds. Practices and policies take into account the burdens that different decisions place on families' caregivers, as well as the complex and sensitive circumstances in which family members and others assume responsibilities to support the frail elderly. So that notion of empowerment goes beyond just an individual focus to a relational focus of the individuals who are working to support people who are elderly and frail. So moving next, thank you, Carol, for advancing these slides. Moving next to the 8th slide, what I want to elaborate on is the ethical value of equity. And equity is equity of access to care that's collaborative, integrated, and effective in improving equitable health outcomes for the frail elderly. And the elaboration point here, and again we'll have a chance to revisit these as we look at the cases that we'll be looking at, this is demonstrated in improved health status and/or improved quality of life for all frail elderly. That's an important point. We certainly are looking toward better health, but in the absence, in a dying trajectory and in the absence of what we might consider to be biomedically good health, we are certainly always looking to improve quality of life. That is an ongoing goal right up until the very end of life, and indeed beyond, in terms of bereavement support for family members and others who have known the frail elderly person. So this fairness then in terms of equity requires non-discrimination based on age and addressing systemic barriers to access such as poverty in rural remote locations. So a point I want to emphasize here is that in our Western healthcare system, we quite often think we are being fair if we treat people equally, treat them the same. And in fact, that's neither ethical nor equitable. What we need to do is treat like situations alike and look for some of the circumstances of people's lives that make it more difficult for them to access what they need in their health or healthcare journey. So that is why that we've pointed to barriers such as poverty, rural remote locations. I would also add, there's many others, but certainly access to language ability such as English and French in Quebec. Those are key issues around equitable care delivery and policy work. So moving on then to the 9th slide, the other value that we're looking at that's at the core of this ethical framework is collaboration in meaningful relationships and projects at all levels of decision making and care. And so what we want to do is have relational processes that mean that people are engaged together in moving this project of TVN and indeed Canadian healthcare forward. So what we've pointed out in slide number 9 is that this requires transparency in decision making so that trust is built and accountability is shared at all levels of research and clinical work. It's manifest in respectful, interdisciplinary, and systematic support of healthcare providers, as well as researchers, policymakers, and public representatives. So that collaboration ought to run all the way from the federal, provincial governments, the health authorities, through to the individual care provider at the bedside, through to family members, others in the community, and of course the individual who is elderly and frail themselves. So that relational network is an important part of the underpinning of this overall ethical framework. And then finally, on slide number 10, is a real commitment to innovation, which is one of the hallmarks of the TVN project overall. And so what we're looking for is innovation in a cohesive, transformative, solution-driven program of research. And for those of you who have been following TVN activities, that's been a real strength in what has been growing over the past years since its inception. So what Dr. Kenny and I have pointed out in elaborating on this last ethical framework value is that innovation is demonstrated in creative and ethical research which addresses directly the effectiveness and efficiency of technologies in the care of the frail elderly, the gaps in current research for these persons and their families' caregivers, as well as complex issues at the end of life in terms of decision-making and care. So it's certainly not only at end of life that we are concerned, but we know that at end of life there are particular supports needed for individuals who are dying and also for the families and the caregivers afterwards. And I do want to note here in elaborating that the support needed afterwards is also for professional caregivers who themselves can have some moral impact from looking after people who are ill, seriously ill and dying in order to carry on that journey. So in terms of one of the final points about innovation then in this 10th slide is that innovation results in accelerated exchange of research results and catalyzes change in healthcare practices and system designs, redesigns, which address the health and care needs of an aging society. And so an example there would be strengthening programs of home care delivery in order to better support people out in the community without always having to rely on hospitalization. And another innovation example that one of the TVN researchers, Dr. Kelly Stadjahar, and her colleagues are leading is looking at the integration of a palliative approach to care that means that even before people are in an active dying trajectory, that the principles of palliative care inform the quality of care delivery and support and ramp up as the patient needs continues to accelerate. So those kinds of innovations are already being sponsored by and supported by the TVN program of research, and this is something that we see as a really important part of the 5 values that make up the ethical framework that I've just sketched out. So what I want to do is to make a transition now to have a bit more interaction with the audience, and realizing that we have a large number of people in the audience, but a good opportunity for you to put in some online questions or comments as we go through these cases. And the questions or comments can be around the cases. Carol will graciously read a sample of those comments and questions to us to help us look at the application of what I've said in relation to two fairly representative stories, if you will, of the kinds of challenges that come up with care of seriously ill older adults. So what I'll do is to start with the first vignette. I'll introduce what's in these 2 vignettes. I'll go through the first one, offer some questions to you to respond to, then go to the second one. So the first vignette is of Jason Stewart, who is a 72-year-old man with a 21-year history of chronic heart failure. Our second case discussion, or vignette, if you will, is April Zhang, who's a 78-year-old woman who has a long history of dementia and chronic lung disease. So let's start then with the vignette, which is on slide 11. where we are going to look at Jason Stewart, who's a 72-year-old man with a 21-year history of chronic heart failure. As you can see on the slide, he's a long-standing resident of a small community in a rural area. His heart failure has become increasingly difficult to manage, and he periodically sees a cardiologist as well as a nurse practitioner in a city, but that city is 3 hours drive from his community. Jason's disease has progressed over the past year, and he's been requiring repeated urgent admissions to the city hospital emergency department. He's just been admitted to the general medical unit of that city hospital, and the team is considering moving him to a do not resuscitate or do not attempt resuscitation status, and meaning that if his heart stops or his breathing stops, he would not be resuscitated and would be allowed to die a more natural death. So given that vignette, what I'd like you to consider and would like to have some sample questions or comments on are certainly anything I've said already about the ethical values, but specific to this vignette, what challenges do you anticipate for Jason, his family, and care providers? What ethical values might be most relevant if we look at that list of 5 I have given you? How could those values direct research, practice, and policy in situations such as this? So certainly we're interested in the clinical example, but we want to look at the application for TVN, not just clinically, but also in terms of how we promote change through research, practice, and policy. So I'll pause there, and Carol will watch for the online comments, and we'll take, we have about a half an hour or so for both these cases, so we can take a few comments, and with apologies to those of you who write in and don't get your questions addressed, but there'll be good representation, I know, regardless. So Carol, over to you to let me know what you're seeing online.
Okay, Patty, I haven't seen anything come up yet, but it sometimes takes a while for people to actually type the question out.
Okay.
Do you want to go on to the next vignette while they're thinking of questions and then go back to it?
Sure, that's probably a good idea. Thanks, Carol. You've got your team has got some good experience with doing these webinar calls. So while you're thinking of questions or comments for that vignette, the second vignette has some similar challenges but a few significant differences. So the second vignette, which is on slide number 12, is April Zhang, who is a 78-year-old woman who has a long history of dementia and severe chronic obstructive pulmonary disease. She's been living in her South Vancouver community with home care and family support, but she was recently hospitalized in a tertiary care hospital for a serious exacerbation of her chronic obstructive pulmonary disease. And for those of you who aren't healthcare providers in the crowd, chronic lung disease or chronic obstructive pulmonary disease is somewhat classic for that there's a lot of ups and downs on the illness journey, just as there is with the congestive heart failure challenge that Jason Stewart had in our previous example. So in this vignette, in slide number 12, April Zhang has just been discharged from the hospital to a long-term care facility. When she arrives, the care aides, nurses, rehab staff, and other support staff feel overwhelmed. Their long-term care facility used to feel like a residence, but they're now seeing increasing numbers of acute admissions of people, such as Mrs. Zhang, who die soon after their arrival. And so when we look at that scenario, we're going to be asking, what challenges do you anticipate in this situation? Similar questions as the first case, what ethical values might be most relevant? What would the long-range implications be for research, practice, and policy in healthcare overall? So those are our 2 discussion points before we get to that we'll synthesize together. So let's go back to that first vignette and see what kinds of comments or questions you might have either about what I've said so far in terms of the overall ethical framework and specifically applied to Jason Stewart, who is from a rural and remote community, is really struggling with his chronic heart failure and has now been moved 3 hours from home into an acute medical unit where he's very likely going to be deemed do not resuscitate. And a piece of context I'll add to that is that in general medical surgical units in hospitals are not well resourced to provide good palliative support for people when we are deciding not to pursue treatment. So I want to add that piece in there, that's often one of the challenges that emerges in a story like Jason's. So let's see, Carol, if we have any comments or questions on the line.
So we do have some comments on the Jason example. The first off, they said the wording team deciding to move him to DNR. The question is, where's the patient's input? And then following that, with travel time, the DNR would be at home. But that can require support for family who aren't trained for end-of-life crisis.
Yeah, thank you, Carol, and thank you, audience members, because those are two absolutely outstanding questions. In a seminar face-to-face format, we'd have some back and forth on this, but you've provided us with some excellent things that I can comment on. You're absolutely right that the discussion about the do not resuscitate ought, and I'm using the word ought purposefully here, to involve Jason and his family, and certainly should have happened well before this urgent admission. What we do know, there's been excellent work to promote the use of advanced directives across the country, but we still are not as fully covered or as working on this as early as we ought to. If we think about the ethical value of respect for Jason as a unique self-determining being, he and his family ought to have had a chance to talk about what he would want as his disease progressed from the beginning of his diagnosis. There's growing literature in cardiac care about the mortality rates of people with chronic congestive heart failure. Those mortality rates can be as high as the percentages for many people with serious cancer. But the culture of cardiac until recently has meant that we tend not to have those discussions as early as we ought to. And it tends to happen, as in this scenario, that DNR, do not resuscitate, is discussed late and at a time when it's less possible to involve the patient and family. So a really important comment from our audience that the patient and family input into this is crucial. It is the patient's, if he is informed and competent at the time, it is his decision, and that discussion needed to have been started from the beginning of his chronic illness diagnosis. This should be true of all chronic illnesses, particularly chronic congestive heart failure, which has a really rocky trajectory, yet a fairly high overall mortality rate in serious situations. So that point is excellent. And at the very least, if it hasn't taken place before Jason got to the hospital, he winds up on the acute medical unit, there needs to be a concerted effort to involve Jason as much as possible and find out who is speaking for him in terms of healthcare decision-making, if he has appointed that individual formally, or follow our processes in terms of next of kin. So thank you for that comment. The second point, the second note then, is about the do not resuscitate, and the fact that a do not resuscitate order for somebody who lives 3 hours away from a healthcare facility implies a significant level of burden in terms of support there. So we picked up on that. We do have a growing body of research about rural healthcare inequities, and it is certainly the case, and this is coming up in a number of studies, including the study of a doctoral student I supervised who finished recently around rural healthcare delivery, that it is particularly patients who require palliative care in rural places who are suffering some pretty significant inequities in terms of their ability to access nursing, medical, and other kinds of home care support to be able to manage both symptom relief and the dying process at home. And there are a number of researchers, including at within British Columbia, the University of British Columbia in the Okanagan, Dr. Barb Pessett and colleagues, as well as leaders at the University of Northern BC, who have been doing a lot of research pointing to the need for more equitable access within rural communities, even to non-professional home care support. The burden on families and patients is significant. And what I have learned from the doctoral student I worked with is it's not just the amount of time from a location, but also how accessible the road is. So, for example, is there a hill and is there a four-wheel drive that will get up that hill in the winter that turns out to be enormously important? And another point I would add to this really thoughtful question is that within Aboriginal communities, our colleagues who are Aboriginal leaders can teach us a great deal about what is needed for better equity of access within Aboriginal communities, which may be in more urban locations, but certainly many of which are in rural and remote locations. And so equitable access for both symptom support and the actual end-of-life trajectory itself is a significant challenge across Canada. I would add, by the way, that the 2002 Romano report that came out around healthcare changes to healthcare delivery that was not implemented, and I hope some of the ideas with the new government federally will be resuscitated, but more equitable rural and remote healthcare delivery and more equitable healthcare delivery for Aboriginal communities were two strong pillars of that 2002 report that we need to make some progress on. This, by the way, shows, I hope, and your questions have pointed to, the link between the individual family patient care to the larger provincial and federal systems that we need to use our research to help make change in. So thank you for those 2 points. And what we can do is go to any more questions on that first vignette before we move on, Carol. Thank you.
Okay, Paddy. For the most part, you have answered a lot of the questions that were submitted, but here is an interesting question. It says, from the patient family point of view, shouldn't it be assumed we know the term Advanced Directives Care Plan? Basically saying that researchers and academics are ahead of the terminology from the living will perspective.
Yeah, thank you. That's an absolutely excellent point. And the research shows that although we have known about the importance of advanced directives, and the living will was an early form of that was popularized some years ago and certainly still is in existence, the research shows that although there's growing awareness of it, we're not doing a good job of implementing it. And while we have gotten better, I would really agree with the participant who wrote that note that we need to do better with educating the public as well as healthcare providers to implement advanced directives. And so and by the way, there's differences across our provinces as well. So some initiatives within British Columbia that I know are mirrored in other provinces have included the production between the health authorities of a really comprehensive document called My Voice that is being used as a patient-family teaching tool and ideally should be introduced to patients' families early in any kind of an illness trajectory. And that helps people think through what might they what kind of decisions might they make, how for healthcare decisions separate from financial decisions. They need to know the substance of what their advanced directives are, what their beliefs are, what they believe at their current state that would be important to them. So the content of their advanced directive is an important thing for them to be able to focus on. And also, so there's the content or the substance of an advanced directive. The second piece of an advanced directive is really also to focus on who do they want to speak for them when they are no longer able to speak for themselves. And so documents such as My Voice give patients and families a chance to really reflect on and grapple with how to implement those kinds of questions. And the The implementation, though, needs a great more public education, and it means that all of us who deliver healthcare within Canada need to be much more proactive about letting people know what exists in terms of advanced directives and teaching, too, what exists within our individual provinces, because there are provincial differences, all of them sharing similar philosophies in terms of both the substance of what you want and who you want speaking for you in terms of healthcare decision making. And in the two examples that we've been discussing in terms of the Jason Stewart with the heart failure and April Zhang with dementia and chronic obstructive lung disease, those discussions should have started at the initial diagnosis stage and then should have been revisited with the primary healthcare provider as time went on. Now, I will also say that Technology Evaluation in the Elderly, TVN, has been doing an excellent job of sponsoring research about how to help make this better, and there is some very good work happening across the country to try to make advanced directive discussions more accessible, more normalized, and not as feared. And so we no longer use the term living will because it was an old form that wasn't as complete as what I just described, but the intent of much of the earlier living will discussions were similar. I will add, by the way, as somebody who's been working on getting this documentation for my aunt, who is quite elderly, that it's one thing to know how to do this in theory, but the actual getting the forms, knowing who to talk to, realizing that ambulances in many provinces will need a different form than other healthcare providers, different documentation, figuring out what's needed, does take a bit of groundwork, and I think we could do a better job of supporting patients and families on that. So those are some comments I would make based on that question. Thank you, Carol, and thank you whoever sent it in.
And Patty, that was sent by Kathy Kastner, bestendings.com, and she's also commented that she loves and respects what you're doing and the findings, and may the findings be properly and comprehensively disseminated and implemented. And thank you for sharing, was her comment.
Oh, thank you, Kathy.
So on the second example, we haven't received any questions yet or discussion points. So maybe based on your conference questions, you might be able to get some of these discussions going.
Sure. So why don't we look more specifically at some particular issues for April Zhang and that second case discussion. Thank you, Carol, for the navigating the comments and the coaching on that. So the two vignettes are here for a reason. So with Jason Stewart, we have somebody who has been at home and now is in acute care. And with April Zhang, we now have someone who has moved from her urban community with home care and family support, but has, as a result of tertiary care hospitalization and her further physical deterioration, is now in a long-term care facility. And one of the things that I want to point out is I've had the opportunity to actually, through Providence Healthcare, there's a consortium of 5 long-term care facilities who have gotten together to look at situations just like this and how to better support the care providers for complex patients such as, or complex residents at this stage, such as April Zhang. And what is happening, and it's beginning, the research literature is beginning to reflect this, is that in years gone by, long-term care residences were literally that. They were residences for people to get nursing care, occupational therapy, physical therapy, other kinds of support to live as well as possible into their generally it was a situation of old age and dying, although certainly there are people who have been in long-term care who've had disabilities and other reasons to be there. But focus was on having people as residents and as creating a sense of family and community. And that certainly still exists. My own background is in acute care, but in working with people now in long-term care on this current research, I've been incredibly impressed by the care providers, both the families and the professional care providers' commitment to creating a sense of home as much as possible. But what we have been seeing, and again, there's growing research that documents this. I've got some references at the back of the presentation for you, and I'll particularly point to, there's a reference by Marcel and Kelly, M-A-R-C-E-L-L-E, and Kelly, K-E-L-L-E-Y, that does an extremely good job of chronicling what I'm pointing to and describing here. What's happening is that because the acute care hospital systems are really strained, and I think that's true right across the country, in terms of shortage of beds, not enough home care support, so that there's a real pressure on getting people like April Zhang out of acute care as soon as they don't need the specialized services there. And that, of course, is an understandable pressure, but in terms of an equitable support for April Zhang, it can create some problems for people such as April, their families, and also creates some downstream problems if April Zhang is sent still fairly seriously ill to long-term care for what basically will be a fairly acutely ill dying trajectory, much more so than used to be in the past. So in other words, what this means is that people such as April are, in a sense, being decanted out of acute care hospitals much more quickly than they used to into long-term care residences and facilities. Again, this is happening across the country. It is a relatively new phenomena, which is why I'm pointing you to the 2015 article by Marcel and Kelly on this point. And we're seeing, certainly including in Providence and other regions in BC, the statistics in long-term care facilities are really showing this as well, that we see a much more rapid time between admission and then death of residents than we used to see on average. And what this does is put, of course, a great deal of stress on patients or residents such as April Zhang, certainly in terms of the grief of her family, but also in terms of the moral well-being and the physical well-being of the healthcare team, who are staffed to look after people who are relatively stable, but are now having fairly acutely ill people to look after who die fairly soon after admission. And so the level of stress and what we've come to think of as moral distress of healthcare providers who are trying to support residents and families in that context has become a significant challenge. Certainly our prime consideration in terms of ethical values, such as the ones that we've talked about, respect, empowerment, equity, collaboration, are very much focused on residents and their families, but they also do apply to healthcare providers. And within my own program of research over the past 30 years, I've certainly learned that if we don't look after healthcare providers, it's extremely difficult for them to deliver the kind of care that patient residents and their families are going to need. So that was some of what I wanted to point to in the contrast of these two vignettes. With Jason Stewart, we have equity challenges around his rural and remote location, the fact that he ought to have had a chance to have some teaching and some coaching before his illness became severe. With April Zhang, similarly, we have somebody who we would hope would now start to have better coaching with her initial diagnosis of COPD and some conversation earlier in her dementia stage about who she wanted speaking for her, what was important to her. And now we have her in an environment where she's dying, where the physical supports for her and her family will be certainly maximized as much as possible, but create certainly a stress for them, April and her family, but particularly here I'm also pointing to the stress for the healthcare team. And so the respect, empowerment, equity, collaboration, and innovation, those values need to apply first to the individuals we're caring for, their families, but also the care team overall. So those were some things I wanted to point to there, and I'm happy to now see what might be popping up that Carol's finding on questions or comments.
Well, that's funny, Patty, because a few comments have come up to actually speak to what you've just discussed, as basically saying acute admissions to the long-term care, that staff at the long-term care facility might not be trained, and as well that family members or other informal caregivers need to help out at long-term care facilities because they're not staffed accordingly. So yes, that seems to be a big concern.
Thank you. Anything else that's showing up there that you wanted to comment on?
The,
I know you're probably having to scan lots of things. Thank you. So you've got the hardest job, Carol. Thank you.
I don't think so, but I think that, you know, people are basically saying overall that, you know, this is what's happening, that people are going to long-term care facilities who might not be able to manage, you know, the people. And I know what you're saying, and that, you know, that might not be the place that they want to be, but that's the only place available right now. But it's not a perfect situation for sure.
No, and there are, and this I think, thank you, Carol, and thank you for the comments for those of you who've written in. This also points that there are, and again, it's where the policy and the research and the leadership of TVN becomes really important, is it is happening. It ought to be the case that the residents, the families, and the care team get more support, and I think TVN research and policy initiatives are in a good place to move this forward. And a sign of hope, for instance, is, for example, in Providence Healthcare, they have funded the first stage of this study where we're actually measuring the stress levels of the all the care provider staff, all the way through from care aides to including physicians and others, to all the levels of care providers in long-term care, to get a sense of their stress. And they have supported us in putting in a WorkSafe BC research application to see for a next stage of intervention. And what shows up in the article by that I pointed to earlier by Kelly and her colleague Marcel and Kelly is that an awful lot of what would help staff is to have not only some continuing education for the increased complexity of the care demands, looking carefully at staffing requirements, but also, and this shows up in research for all healthcare teams, and is probably the most important item I would have on a wish list if it could happen across Canada for care teams, is regular debriefing, safety briefing, the chance to talk about how people feel about their practice, how they can promote better practice to be able to support the values that we've emphasized in terms of respect, empowerment, equity, collaboration, and innovation. Care providers themselves have a lot of thoughtful points to bring forward. It's certainly not the case that they never misbehave or bully or anything like that. They're by no means saints, but in my experience of about close to 30 years now of working with diverse care provider groups, it's by asking the people who are doing the work and listening to them respectfully, empowering them and coming up with ideas for change, that we can make a difference at policy and practice levels much more broadly than just individual one-offs. So I would see that as something that TVN can also and is also focusing on, is the support of care providers. Certainly those family and unpaid care providers are a crucial group who we need to support, but I would also point out that we'll do better overall if we provide ways of supporting the paid and professional caregivers. And a lot of that is listening, have to say that about what will make things better, and giving them a chance to debrief, as showed up in Marcel and Kelly's study.
And that's good.
So I can move on to some closing comments, but I'll just see if there's anything else that's coming up there, Carol, that you, because my closing comments will take me about 10 minutes anyway, but anything else that you're noticing online there that you want to pull out? I want to thank those people who've been typing in. It's awesome.
Yeah, we have received quite a few questions. I think there's just one final one, and I'm not sure if you talked about it, is that April may wish to die at home, which is a growing trend, and instead of going to the long-term facilities.
Yes.
So again, that's, you know, how much choice is being, you know.
Yeah, that's an absolutely excellent point, and thank you for bringing that up. So, you know, in ethics, one of the most important things in thinking about ethics more explicitly, we learn the difference between what is happening and what ought to happen. And those of us in healthcare delivery, research, policy, administration try to narrow that gap. In other words, figure out how to go from what is happening to what ought to happen. And just because people are being decanted into long-term care doesn't mean that that's the way it should be for everyone. And I think what the the participant has pointed to is we need to be able to, going back to those early discussions, to be able to support meaningful choice and dignity, we ought to have conversations before there's a full-blown crisis to say, here are some of the choices in terms of care delivery that we know about as people reach toward the end of their lives, and here are the resources we know that need to be in place along that journey. And so if we're going to support someone like April being at home with perhaps support from her family as well as paid and caregivers that are provided by the province, starting those conversations early is absolutely crucial. And it's also the case that at a policy, a bigger picture macro level, the people who are writing policy provincially and nationally for healthcare delivery have to make meaningful choices available. So that also means, and it's probably one of the most important plugs I can put in, particularly now with the assisted suicide legislation on our horizon, that this has to include meaningful access to good programs of palliative care, where there's symptom relief, support of grief and suffering, family support, and the working toward a meaningful death, whether that is happening in a home, a long-term care facility, or an acute care facility, that access to really robust palliative services ought to be far better integrated in our system than it is. And certainly that requires, in the example question that came up, a much more robust home care delivery system than we have across Canada right now. The home care that does happen is absolutely fantastic, but we need far more of it. And it then does back up to what we said earlier about starting the conversations much earlier. So those are points I wanted to make before moving on to the final slide. But Carol, just to double check before I move on to see if there was anything else that came up.
No, I think that's it. I think you've covered most of the questions, so thank you.
Great. So what I'll do is I'm going to move to slide 13, and I'm going to offer, these are posed as questions for you to take away. I'll offer some comments on, and I'm also going to welcome any closing comments from you as a group. So with thanks to this audience across the country whom I can't see but have huge respect for, so thank you. So what I'd like to do is have you reflect on and write some comments on 5 questions about, if you will, operationalizing an ethical framework to lead the work that TVN is doing across Canada, but also to influence policy and practice within Canada, past the building on the legacy of TVN, and also indeed internationally. These are certainly not just Canadian problems, although our healthcare system does pose some both particular strengths and challenges. So as we close this call, I wanted you to reflect on, and I'll go through all the questions and then just invite any order of comments. We're not in a classroom where you have to answer question 1, 2, 3, and then 4, although I think it's labeled 5 on the slide. But the first question, what do you see as the current relevance of ethics in healthcare and health research for the frail, seriously elderly and their families or caregivers? Secondly, what do you think about the structure and utility of an ethical framework for healthcare, health research, and health policy for the frail, seriously ill elderly and their families' caregivers? Thirdly, in closing reflections, how can the foundational values necessary for an ethical framework specific to the TVN continue to be operationalized in ongoing TVN work? And what are the implications for your own work? If you're on the call as a researcher, can you think about how these values might influence some of your future work? If you're community advocates, what might that mean to you, for instance? And then finally, how might TVN scholars, researchers continue to work to establish the relevance of ethics in technology evaluation for the seriously ill, frail, elderly, and their families, caregivers across Canada and beyond? So I'd like to see if anybody would like to make some comments on that, and then I'll close with my own thoughts as I've been on this ethical framework journey and what I have learned, certainly from my incredibly wonderful colleague, Dr. Sister Nuala Kenny, and also from engaging with participants and researchers within TVN over the past 3 years. But over to you to see what sort of comments might be coming up.
So I haven't received any comments yet, but it does seem to take a few minutes for people to actually type it out.
No problem.
It's too bad we couldn't open it up for questions.
Yeah, that's with this number of people, we probably it would be difficult to manage. So, so what I may do is say a little bit about what some of the conversations we have had with the TVN board have been as these values have emerged. And one of the things that that the TVN board has been, I think, excellent about has really wanting the values to come alive and not just be, one of the dangers of an ethical framework is it can become just a piece of paper that's a poster on a wall on a hospital, or it might be something that's in a book but never looked at. But the TVN board is really committed to making these kinds of values come alive and be actualized. And so in particular, I was fascinated with how they added and emphasized the importance of innovation in terms of changing some of the systems of how we do things in a way that might be more creative and might be something that hasn't been tried before. And so my personal plea for innovations that I would like to see in healthcare delivery that would actualize these values for diverse groups of people. One of them is absolutely to look at more equitable home care access, particularly for rural and remote people, but not only. That includes home care access for people in urban centers as well. That a more robust health home care system would really help people's experiences as they flow through from acute care to home care to long-term care and so forth. We often talk about our healthcare system as if it's in discrete pieces, but one of the things I've learned through this work is that one strengths and challenges in one part of the system really affect the other. So to be able to actualize the kind of ethical practice in terms of respect, empowerment, equity, collaboration, and innovation, home care strengthening, I think, is a key linchpin there. And the second wish list that we have discussed in TVN meetings and that I would hope we would continue to research and do work on is something that I mentioned earlier in relation to April Zhang's narrative, and that is that we need to absolutely make our priority the support of our patients, residents, and their families and their caregivers, unpaid and volunteer. We have a marvelous network across Canada, and I really want to emphasize that we need to pay attention to both the moral distress and the moral well-being of professional healthcare providers at all levels, from care aides who may come from marginalized social positions themselves all the way through to highly paid specialists, researchers, and so on, that our own, looking after our own moral well-being, having the chance to debrief and so forth is a really crucial component of actualizing these values and ought to inform policy and practice work ongoing across the country. So those were two things that I wanted to say, and I'll see if there's a last word I can give to somebody who's typed in a comment that Carol's picked up.
We have no more questions.
Okay.
I think it's because you've addressed everything.
So, and I think we're pretty much 1 minute or so off time in terms of being finished in terms of timing. So just a couple of comments on the reference list. They include references on issues of equity, cultural safety. They include references on, as I mentioned, home care delivery, which is an area that needs, I should say residential care delivery, which is an area that needs more research. They also include, the references also include some work that myself and others have led on looking at the moral distress and moral well-being of healthcare providers, including interventions that we've tried in some action research projects that seem to help. And I want to come back to that regular debriefing as an absolutely crucial foundational standard, that we not just get together to talk about cases per se, but to talk about how are we doing, what are our challenges, how can we move our practice and policy work forward to better support the kinds of values that we've laid out in this ethical framework. So that's where I'll close, and I'll turn back to you, Carol, and just say the expertise of TVN in running this webinar has been fantastic. Thank you so much for your support on it.
Oh, you're very good. I thank you, Patty. It was an excellent presentation, and I have to point out that we received a lot of positive comments about the value of your work and your presentation today. So thanks very much. And
And
I
thanks
will.
to all of you.
Okay, I've got the, in order to, improve our future webinars, there will be a feedback screen that comes up when you close. I'm not sure if it's when you close or when I close it. If you could fill it out and make any suggestions on improvements. I've already gone through the upcoming webinars. So I think that ends it for today. And again, thanks, Patty. That was great. And we'll see you at our next webinar on December 2nd. And have a good afternoon. Thank you very much.
All the best, everybody. Thank you.